the sixth session in our conference, and it concerns the HCV updates. Before I start, I want to thank our colleague Amal Refat, lecturer of clinical pathology, for coordinating this session. But unfortunately, she is not with us today for personal reasons, and we hope to be all of that for her. We have really only 3 speakers, distinguished speakers in this session, and excuse me to postpone any discussion at the end of this session. First speaker, our distinguished guest, Professor Dr. Mohammed Hashim. He's a graduate of the Faculty of Medicine, Cairo University, and there he did pediatric residency. Then he decided to continue his clinical training in the US and completed 3 years of training in general pediatric residency in New York, then a fellowship in pediatric infectious diseases at University of Rochester, New York. 5 years ago, he was appointed assistant professor at the Department of Epidemiology and Public Health in University of Maryland. His main interest is focused on pediatric infectious diseases, particularly HCV, and he's going to talk about cell-mediated immunity in seronegative iviremic children with intrafamilial exposure to hepatitis C.
Thank you very much, Dr. Ola, for your very, very kind invitation and introduction. And thank you very much for the organizing committee for your generous invitation. It's indeed a great pleasure to be here among the distinguished guests. I would like to talk today about work that we have concluded in Egypt and Cairo. The title of my talk is cell-mediated immune response in seronegative aviremic children with intrafamilial exposure to HCV. Probably all of you are aware of these figures, but let me go briefly. Egypt has the world's highest prevalence of HCV. About 15% of the population has antibody prevalence. It has a prevalence of HCV antibodies, with 8 to 10 million having been exposed to the virus. HCV RNA is present in 60% of those exposed to the virus, and close to 1 million Egyptians suffer from chronic liver disease. About 40,000 a year die from liver diseases, which is 10% of total mortality, and peak mortality is anticipated to occur in 2000, has started in 2010 and 12, and will continue for decades to come. Briefly, this is the serological pattern of acute HCV infection with recovery, the favorable outcome. After an incubation period of 7 to 8 weeks, symptoms, if it appears, start and last for 2 to 8 weeks. This is accompanied by a rise in ALT level, which may reach up to 20 to 50-fold, and with a late onset of anti-HCV towards the 3rd month of infection, and continue to increase. Titers tend to decline with time. As early as the first 2 weeks, HCV RNA can be detected through molecular techniques, and it's lost from the blood towards recovery. The unfavorable and more critical course is that of the progressive persistence of infection, and symptoms pretty much are similar to the acute phase, with the difference that the virus remains in blood and the ALT levels drop to normal levels, but with fluctuating course and an increase in the ALT level of about 1 or 2 to 4 increase in the ALT level. One important issue about the HCV RNA in blood for persistence is that there are points where the virus disappears from blood, so it's very important that one single negative test does not mean recovery. This slide shows the natural history of hepatitis C infection with more than 85% of those acutely infected develop persistence and chronicity, and over a period of 20 to 30 years, 20% of those develop cirrhosis and ultimately end-stage liver disease. These symptoms progress more rapidly if there is a co-infection of HIV. Unfortunately, this is not a common thing we see here in Egypt, as well as with alcohol consumption. The favorable course is this that resolves, and it's about 15% of the cases. So I'm trying to focus about what immune response correlates with recovery. Many studies of the host and genetics and immunology demonstrate that the importance of the role of T cell in the protection of immunity against HCV. Studies have indicated that both CD4 and CD8 T cells responses that are broadly directed against multiple antigen and that are functional, meaning producing high levels of interferon gamma and maintain proliferative capacity as well as sustainability over time are linked to virological control. And in acute HCV infection, a vigorous polyclonal CD4 response predicts recovery, and these responses, if persist for years after spontaneous resolution, and if lost, it's associated with relapse of viremia. A vigorous polyclonal cytolytic response has been reported in infected chimpanzee and predicts recovery. And cytolytic response are found in exposed, uninfected individuals. And actually, this what urged us to do this study among children, and this, to our knowledge, is the first study to be done to test for HCV-specific semi-mediated immune response among infected children, uninfected children exposed to infected children. So exposure to HCV can induce an HCV-specific T-cell mediated immune response without infection or seroconversion. And among high-risk population, this has been reported in family members of HCV-infected individuals, in injection drug users, in children born to HCV-infected mothers. And our group have recently published, had recently concluded the study, a mother-infant cohort study. Dr. Samir Khanfri, a member, graduate from Alexandria University, and now in the University of Maryland, looking for a semi-mediated immune response of children born to HCV-infected mothers over 5 to 8 years after delivery. And although these children, some of these children were aviremic and had no antibody in their blood, they showed cell-mediated immune response to HCV antigens. Healthcare worker also among those who are exposed, are exposed to highly endemic regions with, in Monofea. Our group also has published or have a publication in press now about healthcare workers, probably something that 30 to 40% of healthcare workers in National Liver Institute in Monofea University detected HCV-specific semi-mediated immune response to HCV antigens, denoting prior exposure. Prisoners and spouses of infected partners. So our hypothesis that some uninfected siblings of HCV-infected children who are seronegative, aviremic, may have HCV-specific cell-mediated immune response to HCV antigens, indicating probable prior exposure or a possible protective effect. This study was done at Aboitiz Children's Hospital in collaboration with Vaxira, where we did our lab arm of the study. We identified 35 infected children from a study of the natural history of hepatitis C children already recently concluded. And we screened all family members, and of these family members, we identified 45 seronegative siblings and 5 seropositive viremic infected children. These were our index cases. So these seronegative siblings and their infected children, PBMCs were collected from these subjects and co-cultured with HCV antigens, and interferon gamma immune response assay was done. Of the 45 seronegative children, 15 showed a positive CMI response, 30 were negative. None of the seropositive viremic children showed a CMI response. Then we did PCR, HCV RNA testing for the 45, for the 15 CMI positive. 3 of them were HCV RNA positive, 12 were negative. So 12 of 15, which is approximately 80% of them were negative. Finally, for identification of the cells producing the interferon gamma with its flow cytometry. PBMCs were isolated by fical hydrodensity gradient centrifugation within 24 hours of collection, and we used 3 recombinant HCV specific protein antigen donated from Chiron. Interferon gamma ELISpot assay has the advantage of enumerating antigen-specific cells and quantifying cytokine secretion. This is a diagram of hepatitis C genome. It's, as you already know, it's a RNA virus enveloped. We used the C22 antigen, the C100 antigen, and the NS5 antigen. These were co-cultures within PBMC. And our definition for functional viable PBMCs was defined as interferon gamma immune spot assay having more than 1,000 spot forming units per billion PBMC in response to anti-CTC stimulation. And a positive CMI response was defined as a response of more than 55 spot forming units per million cells against all 3 antigens. This is the picture showing different responses to HCV antigen in seronegative cases where this showing no response, minimal response, and high response. And this bar chart is showing the breadth of these responses. We had three patients of the 12 showing a response to the 3 antigens, 5 patients showing response to 5 patients showing response to only 2 antigens, and 4 patients showing response to only 1 antigen. So, this slide is showing the magnitude of the cumulative HCV-specific interferon gamma ELISpot response in median levels among the seronegative aviremic, aviremic group is the 12, the seronegative viremic sibling, and the seropositive viremic in this case. As we can see, the response is highly significant. The response is higher in the seronegative viremic compared to the Higgs cases. The peak both, as well as for the seronegative viremic, the response is significantly higher. There is no much, it's higher in the seronegative viremic compared to seronegative viremic, yet it's not statistically significant. And when this was done on individual antigens, as we can see, the one to the very right, showing that for individual, the NS5 shows the highest response compared to the viremic.
1 minute remaining.
Followed by the C22, followed by the C10 and C22. This shows the flow cytometric analysis indicating that the responses are mainly from CD4, and this is a correlation between the correlation of the CMI responses elicited under the web seronegative viremic patient between the C22, C100, and NS5, showing a negative correlation between C2 and C100, and a positive correlation between C100 and non-saturated. In this study, we had 27% of seronegative aviremic children living in the same household with their infected siblings were hyperemic and had a positive HCV specific interferon gamma immune response.
Your time is up.
Two-thirds of the children responded to 2 or more HCV antigen, and probably this is represent a true response to HCV rather than a cross-reactivity of other antigens, which we would have expected to be similar to all groups. The frequency of children responding to NS5, non-structured protein 5 antigen, was the highest, followed by C100, the non-structured protein C100, then the structured protein C22. The magnitude of the response detected was highest for non-structured protein 5, followed by C100 and C22. Phenotypic characterization of interferon gamma producing cell was assessed by flow cytometry and confirmed that CD4 T cells were the source of interferon gamma. And a substantial percentage of HCV seronegative aviremic children are potentially exposed to the virus, have a broad HCV-specific cell-mediated immune response, and which may have protected them from a possible infection and subsequent exposure. The persistence of this T cell-specific response is both structural and non-structural protein in infected, uninfected, healthy family members is secondary to an immunological memory, providing antiviral protection and maintaining this effector T cell responses. Induction of a robust T cell response through vaccination could provide effective immune control of acute HCV infection, and the evaluation of, we hope that this cohort will be evaluated for persistence of HCV-specific immune response, and to determine whether it remains protected or not. And we want to examine also the correlation between IL-28, IL-28B polymorphism with HCV-specific semi-mutated in this same cohort. And I would like finally to thank all those who worked in the study, Dr. Hanay Araksi, Eva Helmi, and Dr. Gamal Asma from Cairo University, the group from Baxira, Dr. Saifik Abdullah, Maha Sofi, and Dr. Julian Galel, and from National Pathology and Tropic Medicine Institute, Dr. Suzanne Neri. Finally, my colleagues from Maryland, Dr. Samri Kamari, Dr. my mentor, Thomas Strickland, and Dr. Tarek Shata from Cincinnati. Thank you.
Thank you, Dr. Muhammad, for a very interesting and very hot and important topic Of course, it needs a lot of discussion and inquiry, and this will be at the end of the session. Next speaker will be Professor Dr. Abir Hadidi. Dr. Abir Hadidi will give us a talk on HCV-associated thrombocytopenia update. Dr. Abir. Yes.
First of all, I want to thank all my professors and colleagues, and want to thank Dr. Nadia Zaki to give me a chance to equate this presentation to you. The presentation today will be about hepatitis C virus-associated thrombocytopenic update. I will explore to you our project done in our Faculty of Medicine in Alexandria Clinical Research Center. The title of the project, Hepatitis C Virus-Associated Thrombocytopenia in Egypt, Study of Etiology and Response to the Razole Therapy. The PI of the project, Dr. Nadia Zaki, Professor of Internal Medicine Hematology Unit. The co-PI, Dr. Amar Refat Mansour, Lecturer of Clinical Pathology, and I am proud to be one of members of this project. The project funded from Alexandria University Research Fund, Research Enhancement Program, and extract. The project partner, Faculty of Medicine, Medical Research Institute, and Faculty of Pharmacy, and lastly, High Institute of Public Health. Egypt has the highest prevalence of hepatitis C in the world. Thrombocytopenia is one of the most frequent hematological manifestations of HCV infection, which can become a major clinical complication. It may be present even in absence of clinically evident liver disease or splenomegaly, and may be wrongly diagnosed as chronic ITP. Thrombocytopenia with HCV patient either pre-exist and prevent initiation of treatment with pegylated interferon, or develop as a consequence of treatment with interferon, leading to dose modification in 19% of cases and discontinuation in 2% of cases, and the dose reduction of 20% are associated with decreased antiviral efficacy. This table shows the prevalence of hepatitis C virus infection in adult patients with chronic ITP. An Egyptian study done by Swivi and Tabifi in 2007 reported that 18 cases out of 42 cases of chronic ITP were HCV positive as detected by ELISA and PCR. The etiology of thrombocytopenia in hepatitis C patients is still obscure, but there are several possible mechanisms. It may be non-immune mediated, either direct infection of platelet and megakaryocyte by HCV, or hypersplenism leading to sequestration of platelet in enlarged spleen secondary to portal hypertension, or inadequate production of thrombopoietin, and this area is controversial. Or it may be immune-mediated due to production of antiplatelet antibody, or high affinity binding of HCV to platelet membrane with subsequent binding of anti-HCV antibody might lead to phagocytosis of platelets through an innocent bystander mechanism. Management of thrombocytopenia in HCV patients, as yet no treatment consensus in the literature. There are several theories may give steroid, interferon alpha, erythropoietin, splenectomy, splenic artery embolization, human recombinant interleukin 11, and thrombopoietin receptor agonist. The thrombopoietin receptor agonist available in the market, two available agents, either M-plate or L-thrombobag. The only L-thrombobag is tested in HCV-associated thrombocytopenia, but the concerns about this treatment include it may increase bone marrow reticulin, and it may lead to rebound thrombocytopenia, thrombosis, and in one study of MDS it increased in circulating plasma. Plus, it's very expensive, and so we need another agent to be less expensive and it will be effective, inshallah, as a derivative of synthetic steroid, which is a danazole, which is a modified testosterone, successfully used before in treatment of chronic ITB, and it can be a novel alternative treatment for HCV-associated thrombocytopenia, according to a recent research presented in 58th annual meeting in American Association for the Study of Liver Disease in Boston in 2007. An open-label clinical trial of 41 patients with chronic HCV, 90% of them with liver cirrhosis. This study was in 2007. 26 patients received danazole at 300 to 600 milligrams per day until the end of HCV therapy, and 15 was as a control. Only 23 patients follow up. 12 of them had good response, and 7 were mild responder, 4 were non-responder, and only 2 developed reversible cholestasis, which is a side effect of danazole. The authors of this study concluded that HCV patients receiving the standard treatment of interferon may become thrombocytopenic but are able to achieve increase in platelet count through danazole therapy. The mechanism of action of danazole to increase the platelet is it may lead to impairment of macrophage-mediated clearance of antibody-coated platelet via decreased FC receptor expression, or it may lead to increased thrombopoietin levels. So in our study, we estimate thrombopoietin by ELISA after the end of danazole therapy. Till now, no randomized or controlled clinical trials testing the drug in such an indication have been conducted. The only studies done before were open label, but our study is blinded. The danazole as cost effect is it's cheaper than L-Thrombobag and Nplate. It's only cost $110 per month, but L-Thrombobag and Nplate cost thousands of dollars per month. Treatment of patients with HCV-associated thrombocytopenia is an important and unresolved problem, particularly because the mechanism responsible for thrombocytopenia in these individuals remain unclear. Our study objective to assess factors underlying HCV-associated thrombocytopenia in Egyptian patients and to assess safety and tolerability of danazole, to determine efficacy of danazole as a treatment of HCV-associated thrombocytopenia compared to placebo by assessing the number and the percentage of subjects whose platelet count increased significantly, permitting initiation of antiviral therapy, and who maintains their platelet count more than 100,000 during 12-week follow-up period after discontinuation of danazole therapy. To correlate the various etiological factors with the response to danazole therapy, and to correlate the data above with plasma danazole concentration, to determine the cost effectiveness of using such therapy if effective. Our subject, 150 subjects with chronic HCV, classified into 2 groups, group with 50 subjects with normal platelet count, and other group 100 with thrombocytopenia. Eligibility for enrollment in our study, the inclusion criteria, age more than 18 and less than 60, and HCV detected by PCR, ALT and AST less than triple the upper limit of normal to avoid side effect of danazole, and also serum alkaline phosphatase and gamma GT less than the upper limit of normal, as danazole can cause cholestasis. Total serum bilirubin less than 1.5, albumin more than 3, prothrombin activity more than 50%, hemoglobin more than 11 in males and 10 in females, and total leukocytic count more than 3,000. Exclusion criteria is less than 18 and more than 60, concomitant hepatitis B infection, ALT and AST more than triple upper limit of normal, alkaline phosphatase or gamma GT more than upper limit of normal, intra or extra hepatic cholestasis, ascites or hepatomegaly, hepatocellular carcinoma or other malignancy, other causes of thrombocytopenia, other causes of chronic liver disease, prior ongoing therapy with interferon, pregnant or lactating women, renal disease, diabetes, thyroid, and polycythemia, epilepsy, migraine, all of these exclusion criteria for our study. Also, history of androgenic reaction to previous gonadal steroid therapy and concomitant indication with oral anticoagulant, carbamazepine, phenytoin, and other drugs. the project scheme, part 1 of our project, to know the cause of thrombocytopenia in HCV patients. All our patients, after we do the platelet count, classified to hepatitis C patients with normal platelet count and those with thrombocytopenia. All patients subjected to routine hematology and chemistry, immunological profile, serum thrombobitin by ELISA, bone marrow aspiration if we suspect hypersplenism, and HCV in RNA of platelet to detect if there is infection of the platelet. The part 2 of the scheme to detect the safety, efficacy, and the pharmacokinetics of danazol in patients with HCV associated thrombocytopenia. Patients with thrombocytopenia after they write informed consent, divided into 2 groups. The first group take danazol for 24 weeks, and the other group take placebo. And after, and we follow up the patient every 4 weeks for 24 weeks, and after 12 weeks of discontinuation of the therapy, the evaluation done clinically, laboratory, and by estimation of plasma danazol. The informed consent form, signed and dated, and the patient received 1 copy, and the other copy kept in the file, in the study file of the project. This time frame of our project, we already finished our 2 years, and we asked for extension for another 6 months to finish our research. The scientific importance and the expected benefit we want to get from our project, highlighting the prevalent underlying factor for HCV-associated thrombocytopenia in Egyptian patients, and testing a cost-effective, potentially useful option for treatment of this difficult problem, or at least providing short-term support of platelet count during interferon therapy based on the pharmacokinetic data, and thus maximizing the antiviral efficacy of this therapy. This paper, published in December 2011 in Mexico, they prove that danazol improves thrombocytopenia in HCV patients treated with interferon. And they conclude in the end of paper that danazol can be used along with interferon to treat thrombocytopenia in patients with HCV. If we use danazol, we can solve this problem to give interferon with patients with thrombocytopenia and have HCV. And this is the Alexandria Clinical Research Center where our project takes place. We try to balance the 2 goals. To protect our subject welfare and right is more important for us for advancement of science. Thank you.
Thank you, Dr. Abir. برضو الحقيقة موضوع الثرومبوسيتوبينيا والHCV very practical, very important. A lot of discussion waiting for you, Dr. Abir, at the end of the session again. Last speaker for this talk, our Professor Dr. أيمن الشايب. الحقيقة أيمن من أساتذة تروبيكال ميديسين اسكندرية المميزين جدا، وليه باع كبير وخبرة كبيرة في السايتوكاين ستادي والموليكولار بيولوجي والإيميونولوجي، وعاوننا دايما توكس وريسيرشز على مستوى عالي جدا في هذا الموضوع. والنهارده بيختلط موضوع مهم جدا في الباسل كارسينوما. عنوان بتاع الدكتور أيمن serum IGF-BP3 is a more effective predictor than IGF-BP3 and IGF-BP2 for the development of basal carcinoma in patients with chronic HCV infection. Dr. Ayman.
Thanks also to the organizer committee for inviting me to participate in this meeting. Our talk will entitle Serum Insulin Growth Factor Binding Protein 3 is more effective predictor than IGF-1 and IGF-2 for the development of hepatocellular carcinoma in patients with chronic HCV infection. And this is part of a study that was done in the Alexandria Clinical Research Center and was funded by the STDF. Hepatocellular carcinoma is the 3rd most common cause of cancer mortality worldwide. It contributes to 14.8% of all cancer mortality in Egypt, with a high incidence in males than females. The high incidence of HCC in Egypt is attributed to the high prevalence of hepatitis C virus. HCV is currently the most significant public health problem in Egypt. Chronic hepatitis usually leads to the sequential occurrence of liver fibrosis and cirrhosis with high risk of development of hepatocellular carcinoma. It has been estimated that 20% of HCV-infected patients develop liver cirrhosis and approximately 40% of those patients develop HCC within 10 to 15 years. The insulin growth factor signaling system is an essential regulator of growth and development. IGF-1 has a strong effect on cell proliferation and differentiation and is a potent inhibitor of apoptosis. Several authors showed that during experimental hepatocarcinogenesis, the IGF-1 receptor, which mediates the IGF-1 and the IGF-2 signals, and its downstream proteins are initially overexpressed in free neoplastic foci, which may reflect that hepatocytes in their early stage of transformation are more sensitive to stimulated by circulating IGF. This overexpression is gradually reduced in later stage of the disease and is almost completely lost in fully differentiated HCC cases. The liver is the major site of IGF-1 production. Serum IGF-1 levels are influenced by many factors including age and nutrition, but growth hormone, which is the principal regulator of IGF-1 production in the liver and secretion into the bloodstream. The bioavailability of the insulin growth factors is modulated by high affinity binding proteins, which range from 1 to 7, of which the liver is a significant source. Most of the IGF-1 in the secretion is bound by the IGF binding protein 3, whose circulating levels are more than 10-fold higher than any of the other binding proteins. Patients with liver cirrhosis should be carefully monitored for the detection of HCC. Currently, surveillance for HCC development is based on 6 months alpha-fetoprotein determination and the ultrasound examination. However, alpha-fetoprotein levels don't discriminate between benign liver disease and the HCC. Additionally, they have poor sensitivity and specificity and vary with etiology of the liver disease, treatment, and tumor size. Therefore, it is of utmost importance to identify sensitive biomarkers that allow the prediction of HCC development at an early stage and at the same time are easily measurable and minimally invasive. Our aim was carried out to investigate whether serum level of IGF-1, 2 and the IGF binding protein 3 may be used to discriminate between stages of hepatic dysfunction in Egyptian patients with HCV-induced liver cirrhosis. Moreover, whether they may be used individually or in combination as biomarkers for the development of HCC and to correlate these levels in HCC stage. Our study was carried out on 241 subjects classified into 3 groups as follows. Group 1, 79 patients with chronic HCV and liver cirrhosis, which were further stratified according to child park classification. Group 2, 62 patients with liver cirrhosis and HCC, and Group 3, 100 age-matched controls. The following groups were excluded from our study: those with diabetics, obese patients, BMI more than 30, hepatitis B patients, autoimmune hepatitis, and alcoholics, and those all taking hepatotoxic drugs. All the patients and controls fall to the complete history taking, complete clinical examination, nutrition assessment, including BMI, routine laboratory investigation, liver function test, viral markers, serum level of lipoprotein, abdominal ultrasonography, triphasic CT for diagnosis of HCC cases, and staging using according to the Barcelona Clinical Liver Cancer Staging System. Estimation of serum IGF-1, 2 and IGF binding protein 3 using ELISA technique. These are the 3 study groups, including clinical parameters. We have 79 patients with liver cirrhosis classified into child A and B and C, 11 patients with child A, 29 child B, and 39 with child C. These people show the mean level of the IGF-1, 2 and the binding protein C and the alpha-fetoprotein in our patients with the cirrhosis and hepatocarcinoma, as well as in the control group. The mean level of IGF-1 was significantly lower in patients with cirrhosis and the HCC than in control. Moreover, it was significantly lower in HCC patients than in patients with liver cirrhosis. Regarding IGF-2, the mean level was significantly lower in patients with cirrhosis and the HCC than in the control, while no significant difference could be observed between those with HCC and patients with liver cirrhosis. Regarding insulin dose binding protein 3, the mean level was significantly lower in HCC and cirrhotic patients than in control. Moreover, it was significantly lower in patients with HCC than in cirrhosis. This figure shows significant negative correlation between each of the three parameters and child-back score. The only one of that was negatively correlated with alpha protein was insulin growth factor binding protein 3. These pictures of triphysic CT showing multiple heterogeneity enhancing HCC that involves left and right hepatic loops, and triphysic CT showing a large solitary and heterogeneity enhancing HCC in the left hepatic loop, and we found negative correlation between insulin dose factor binding protein 3 and the tumor size, but was not statistically significant. Regarding the diagnostic accuracy, sensitivity, specificity, and the post predictive value, we found that the insulin dose factor binding protein 3 carries the high diagnostic accuracy, 84.3%. And in addition, when combined with either IGF-1 or the IGF-2, the incidence and sensitivity does not increase to that degree. And finally, we can conclude that although our results have shown that serum IGF-1, IGF-2, and the insulin dose factor binding protein 3 are reduced with progression of hepatic dysfunction, only IGF binding protein 3 among them may be considered as the most promising serological marker for the prediction of the development of the HCCs among Egyptian patients with chronic hepatitis C and liver cirrhosis. And the future studies should be directed towards understanding the association between the serum and their tissue factors. Thank you.
Thank you, Dr. Ayman, for this concise and valuable presentation. And now we'll allow only 10 minutes for discussion. Okay? Dr. Muhammad Hashim.
Thank you, Dr. Muhammad, for a very nice presentation. I'd like to ask you about the Alice part. Of course, this is homemade. Yes. How do you read it? You count the colonies visually, or you have a machine? You have. Yeah.
On the left first.
Yes, I know.
It's CTL4 from Cincinnati.
And about the flow cytometry, I would like to understand a little bit what you deduce from your flow cytometry. You just counted the cells, the T cells and the B cells, or what else?
No, we cultured, we used C100.
You have cultured outside and then you counted
yes. And then counted, I think it's a three color four color flow cytometry. And it was just to determine the phenotypic characterization of the cell-producing interferon gamma. And since we are using proteins, it was the CD4 positive T cell.
Oh, okay. And also clinically, because you're a clinician, what does it mean that the child is HCV antibody negative and is viremic? Mm-hmm. What do you mean? Is it window phase? Or
no, it's initially within the first 2 weeks of exposure, SVRNA is detected in serum, and then so this is an acute infection.
Yes, I know, but these are siblings.
They're
not complaining or anything.
So you are asking about
the explanation, the clinical explanation, because you studied a big group and you found a group of them who are HCV antibody negative, and they are viremic.
Antibody negative and viremic.
And viremic.
So
I'm asking.
Yeah, the only explanation we have is that these are acute stage.
So you caught them by chance?
We caught them by chance. We screened all family members of these cases which were infected, meaning antibody negative, RNA negative, and we identified children who were antibody negative. And further testing for HBRNA that turned to be positive. We followed these children for 6 months later, and they turned to remain antibody negative, RNA positive.
How?
It could be that delayed seroconversion. We really don't have an explanation. It could be delayed seroconversion.
And did you get the viremia from the peripheral blood or from the liver or body or what?
Serum.
Just serum.
No,
this is very strange because these are
unusual.
supposedly healthy children.
It's
or
unusual. It's unusual, but we're now.
And what was the viral load? Was it high or low?
Unfortunately,
I don't have the data.
this is a very limited budget project, and we had.
I think this is very serious because this means that they have the virus and there is no antibody response. It's I can't find a proper explanation for this.
I mean, it's the same as we are finding a CMI response without the virus and without an antibody.
No, this might be a form of immunity. They are immune and they get exposed.
Yeah.
And we don't understand this area as yet, but
Yes.
maybe they are protected. But the other way is not difficult to understand.
We really cannot. We did not find
Needs further,
a satisfying explanation for
And
it.
about the viral load, I would be very interested to know.
Unfortunately,
the viral load.
these were conventional PCR. We did
Just
not.
positive and negative.
Yes, yes. Actually, we are currently. I'm involved in another study funded by the European Union, the FP7, and looking into acute HCV infections. And we are seeing over the past year or so, or less than a year, we've seen something like 10 to 12 acute HCV cases that probably something like 50% of them lost their, became aviremic within our follow-up period.
But definitely they have antibody response.
They have antibody response.
That's why I'm not.
Yeah.
Okay, thank you.
دكتور محمد هو الحقيقه بالنسبه للانترافاميليال انفكشن of HCV دي a question mark, a very big question mark for that because it is rarely an intrafamilial. It is more with HPV. يعني لو كان study اتعملت في البي it would be more logic because it's very difficult to get an intrafamilial infection for HCV between mother and man, between children. Even the breast milk is minimal to give the infection. So how can you judge intrafamilial infection? Especially in our country, you studied in the Kafir or Sharia like that, and you have a lot of people, the mother and the father, they have a lot of parasitic diseases and schistosoma and others, which alter the same legitimate immune response. So how can you judge is a pure response or not pure? And again, if it is an acute infection, how can you judge that the same develop response in the acute stage of that? And especially if it's negative, we don't have this. Actually, it's very difficult practically to get a patient with negative antibodies and viremic at the same time, except in the acute stage, and you don't expect CMI response in that.
That's true. It's unusual, but and as I explained, we really don't have satisfactory explanations of this. But there has been multiple studies reporting intrafamilial transmission, larger studies from Delta region and from Upper Egypt showing this. So and also studies showing either incident studies showing people studies showing cohort studies followed over years and showing that there is an increased incidence in children contracting the virus. Actually, there was a recent study, I don't remember the figures, by the late Dr. Mustafa Kanaf, that showed that if the mother is infected, the risk is very high, followed by the father, followed by sibling.
Yes, how can transmission? How can you explain this?
Transmission is it the usual? There is nobody has identified.
Yeah, it's very difficult to prove
unless you do a phylogenetic analysis and determine that.
You have a lot of instances with different means, but actually intrafamilial it's difficult to explain.
It's difficult to explain, but yeah, I agree. I totally agree.
Yes, but for HPV, it's very easy to explain. If we did the same study for HPV, it would be very, very
yes,
easy.
but they're both blood-borne infections.
Yeah,
And
for BO.
If the same reason apply for HPV, then they apply for HCV, except that HPV is more infectious.
Yeah, is it predictable for prevention or protection of these for the long run?
The fact that we have children who are exposed and uninfected means that they have been either they got infected and they result this acute infection, and I explained that our group has recently published a study in press right now. Dr. Camry is about verticals, a mother infant cohort from Spain, and children of born to HCV infected mothers have been followed up to 8 years of age. Some of them were viremic after delivery, and they lost their viremia. And in parallel, we were able to determine HCV specific cell-mediated immune response 8 years after delivery. So our interpretation that this immunity protected this HCV T-cell mediated immune response was sufficient enough to protect them from
1 minute remaining.
Yes, okay, Dr. Sam.
Can I ask?
Thank you very much.
I would like to ask Dr. Ayman for his talk.
Finish Dr. Muhammad first. Dr. Muhammad finish. Any question for Dr. Muhammad Hashim? Yes, yes. Yes, sir. One by one.
I would like first to thank Dr. Strickland because I have participated 15 years ago in a study involving 3 villages, 2 in Monofrea and 1 in Zaba Egypt. And we have screened the whole village. There were 70,000 for, I think, 5 years, and we determined the intrafamilial transmission of HCV. Thanks to Dr. Strickland, who has participated in this study. And my question is so simple. What, in your opinion, the main obstacle that Your time is up. we don't have HCV vaccine until now? Why we don't have this vaccine, in your opinion?
in HCV vaccine.
Why we didn't develop until now HCV vaccine?
I think the main problem was that there is no cell culture for HCV. This is one important thing. And the only animal model for HCV is chimpanzee, and this is a very expensive thing to have to do tests. One of our colleagues, Dr. Shata, has been working on chimpanzee, and my guess is it's costing like $70,000 to $80,000 per chimpanzee, and it's very difficult to maintain. And they used it as a model to give low doses of HCV infection and test on long-term follow-up the HCV T-cell immunity. This is one. The second thing. The other thing that it's the high mutation of the virus, which is much higher than HIV. So this makes it more difficult to develop a vaccine. But I think there is a very recent paper published this month, this month in Nature. I think it's in Translation Science. It's by the group by Paul Flannery, and they have did a construct adenovirus vaccine with a non-structured protein, and as a phase 1 trial, and it's been concluded, and they're moving on to phase 2 trial. And the results of this study, I can keep it here for you guys. And the results have been very promising. It has been immunogenic, and it has an anamnestic response, and it's long term. It has been tested for a year or so. So we are getting there, but these things take time, and it took. I mean, HCV has been discovered in the late 80s. And compared to HIV has been discovered earlier, but from the early 80s till now, there are more than 41 FDA-approved antiviral therapies to HIV, compared to HCV, maybe 1 or 2, in addition to interferon and ribavirin, which are not really tailored for HCV. So there is a lot. We're getting there, I think, but there is a lot to do.
والحقيقه تقريبا هنا الفاكسين is coming very soon. ان في طبعا الشمبانزي ستادي ستوب من حوالي 5 سنين عشان زي ما قال الدكتور محمد ان فيري اكسبنسيف دايت. الشمبانزي الثلاثه بيشتغل عليهم معاهم ثلاثه ما عملناش اي فاكسين. لكن مع ديفلوبمنت اوف نيو ثيرابي فور اتش سي في ناو بالانتي انزيم ثيرابي وظهر منها حاليا موجود النيوكليوزايد انالوجز في ستيل synthetic vaccine is hand in hand going on phase 3 now. synthetic vaccine من الانتي انزيمز يمكن على نهايه السنه دي في بوسطن هيكون في فاكسين and the monotherapy for the virus. The virucidal drug is coming, nucleotide analog with the vaccine, synthetic vaccine. For time is short. Next speaker, Dr. Abir. Thank you, Dr. Muhammad. أي question, Dr. Abir? وهنا كومنت صغير عن دكتور عبير برضه عشان الموضوع فيري هوت.
أنا عندي كويشن.
عندي كويشن. حاضر بعد الكومنت حضرتك تسأل. الترومبوسايتوبينيا حضرتك اشتغلت عليها في جزء منها ريليتد للانترفيرون ثيرابي وفي جزء ثاني اسمه اكسترا هيباتيك مانيفستيشن اوف اتش سي في which الروتين تتنازل لكل الناس وهل هو كل الناس اللي عندهم فيها في الانترفيرون بيجي لهم. احنا طبعا في البراكتس بنشوف عدد قليل جدا اللي بيجي له ترومبوسايتوبينيا ريليتد تو انترفيرون يكاد يكون 10% or 15% which is too short without interferon. A lot of cases حوالي 11% من المرضى عندهم extra hepatic manifestation HCV related which must be treated with interferon. So how can you give this a routine for you? ولا في حالات thrombocytopenia and what amount of thrombocytopenia you need to give them as well? What are your guidelines?
I would like to thank the organizing committee of this meeting, also Amal Rifat for her efforts in performing the lab part of this project.
Very good.
فحطينا ان احنا ناخد العينين اللي بتدي الطن اقل من 100 وناخد التفيوثيرابي وناخد النورمال فات الطن اتش سي بوست ادميشن برضه عشان نعمل الجزء بتاع اللاب اللي هو نعمل منه الباثولوجي او اتش سي بي اسوشيتد سيستميا سبيسيفيكلي ان ايجيبشن بيشنت. حتى عملنا كمان البي سي ار الاتش سي بي ار اللي في البليتلت ولقينا الحقيقه في الجزء ما خلصش لسه بس لقينا في جزء كبير منه البليتلتس ار انفكتد
نفسيه وبص ده شغل تعب. بس في كومنت على المية دي كتير جدا. احنا عندنا بيشنت في وصل 60 يس سيروب مش كل حالات ال100 بنوقف. احنا بندي 60 و70 بياخد الانترفيرون ويكمل الاخر لان في ديفرنس بين الترومبوسايتوبينيا اند ترومباسينيا. Some patient have thrombocytopenia 120 وبيجي له بليدنج ما قدرش يكمل وفي 90 و70 و60 completed the course without. So we have to differentiate between thrombocytopenia, thrombocythemia, thrombocytopenia related to drugs and thrombocytopenia related to extrahepatic manifestation. But your project of course انت خدتي selection لمجموعه مش كتير قوي. ده very important topic لان ده ساعات بيوقف تريتمنت واللي هو ماسك المفروض يكمل والعكس صحيح. الرقم مش كفايه. Function is very important. thrombocythemia sometimes more important than thrombocytopenia. Thank you very much. Your question, last question for Dr. Abir. immune thrombocytopenia. immune thrombocytopenia.
انا عاوز اسال بقى يعني انت دلوقتي زودت العدد بس هل انت متاكد ان الفانكشن بتاعت
لازم تبقى اسوشيتد في دي حاجه ثانيه، ما تاخدش بالعدد فقط. احنا بنعمل معادله في ايكويشن معروفه امتى تستوب انترفيرون او تجيب دانازول. لازم معادله مش بس ترومبوسايتس نمبر، لا نمبر وفانكشن وبليتد، حاجات كتير قوي بنحطها في الاخر. يو كان كومبليت اور نوت. سام تايمز تستوب انترفيرون ما نكملش، وسام تايمز ندي دانازول، وسام تايمز ما ينفعش.
خصوصا الميكانيزم بتاع الدانازول نفسه ان هو هيسيب لك الانتي بودي
يس از سيمبتوماتيك تريتمنت. ثانك يو. دكتور ايمن اخر اي سؤال؟ دكتور ايمن. دكتور مصطفى اتفضل.
I would like to ask Dr. Ayman about is it right that, for insulin growth factor hydroprotein C to be a predictor because you choose your category hepatocellular carcinoma already, hepatocellular carcinoma. For example, alpha-fetoprotein FGFC L3 can be considered as a predictor of carcinoma in cirrhotic cases. So if you measure the FGFC and found more than 10%, you can predict that this case can later on has hepatocellular carcinoma. But all your cases are hepatocellular carcinoma, it's right already. So I am just only for the web predictor.
Okay, thanks, Dr. Mustafa. But we say predictor because we depend on our patient with liver cirrhosis. We included about 79 patients with liver cirrhosis classified into 3 groups, child A, B, C, according to the parameters which are bilirubin atom and the thrombin aside and encapsulose. And we found that the insulin factor bioavailability is significantly lower in patients with child class C and B than in those with child class A. Moreover, was significantly lower in those with child class C than in those with child class B. So the term, and also we compare those with HCC and those with child class C with liver cirrhosis, and the level was significantly lower in those with HCC. So the term predictor meant that we can use this parameter in follow-up of patients with advanced liver cirrhosis for early detection. As regarding alpha-fetoprotein LSD, I think no studies were done up till now compared between this parameter and the alpha-fetoprotein. We have only one thesis in our department following this point of view. But all the papers that started before say that alpha-fetoprotein L3 less than 20 nanogram per ml can discriminate between those with prime liver lesions and those with HCC.
الالفا فيتو بروتين وكل الجروث فاكتورز، فده اللي هيحدد احنا بنرلاي اون وات which is more sensitive which is more specific. لكن prediction means before beyond development of HCC، وده الاهم بكتير. مش ميزه لشخص انت اوريدي موجوده، لكن عايز بريدكت ان انا بريفنت اذا كان في فرصه للبريفنشن. فينيش. Thank you very much for all, and we'll come to the end of this session. Thank you.